Hello, hello, and welcome to Talking All Things Cardiopulm. I am your host, Dr. Rachel Burriesci. Before we get started, I want to give a big shout out to our sponsor, Jane. Jane is an all-in-one practice management software that offers a fully integrated payment solutions called Jane Payments. Although the world of payment processing can be complex, Jane Payments was built to make things as simple as possible to help you get paid. And it's easy to get started. Here's how. Head to jane.app/payments to book a one-on-one demo with a member of Jane's support team. This can give you a better sense of how Jane Payments can integrate with your practice by seeing some popular features in action. If you know you're ready to get started, use the code CardioPulm1MO for a 1-month grace period while you settle in. Jane's promise to you is to be transparent with their rates and provide unlimited support from a team that truly cares. Thank you again, Jane, for your sponsorship. And if you are in private practice, if you have your own clinic, if you are a mobile PT, if you are just starting out in a side hustle and you are looking for an EMR, please check out Jane. Use code CardioPulm1month or 1MO. I have nothing but wonderful things to say about the EMR system. It's easy to use, easy to customize, and it is a wonderful company to be working with. All right, so wanted to kind of jump in and talk about breathing today. I just got back from a trip in New York, just give you a little life update. Went to go visit family, had a little bit of beach time. If you follow me on Instagram, lots of water pictures and moments over that course of the week. It is one of the many things I miss about the East Coast, besides family, is just being in the water, being on the beach. The power, the energy, the calm that comes from that environment is just something special to me. So had a really great trip, refilling the cup, and we're back. And so we're back to recording. So I realize I haven't talked a ton about breathing, and I know I've kind of put it in a couple of episodes, but I really want to make it a bigger point. And it's something that I truly believe to my core has so much benefit across the spectrum, and is something that I typically sell to my students because I'm going to be real, as transparent as I always am. Cardiopulm has been told to me that it's not sexy, and people don't think they're going to use it out in the real world in clinic. And I have to give you a blatant false. We should be using these techniques. And if you're a student and you're in your program right now and you're going to be an outpatient ortho clinician, great. Here's 2 things I'm going to tell you. 1, keep an open mind. Learn as much as you can. Make sure that you get a lot of experience, not just in outpatient ortho, because sometimes you're surprised something else sticks and you start to feel passionate about a different setting. There is nothing wrong in that. And 2, if you use cardiopulm, if you use neuro, if you use your vestibular techniques in that setting as an outpatient ortho person, you will be better. And I promise you with all of my being that breathing is something that every single human should know how to do. And it's so interesting, right? So I'm primarily in the acute care setting, and my primary population tends to be older geriatric population. Most of my patients haven't had any coaching in breathing. I have a number of patients that I see that have COPD, interstitial lung disease, asthma, heart failure for years and years, and no one has taught them how to breathe. And as soon as you meet that patient, because you tell them we're going to do diaphragmatic breathing, and that's a new word. And yes, it's an anatomical body part, and maybe it's not layman's terms, but for the most part, the younger generations have heard diaphragmatic breathing or diaphragm breathing or activating the diaphragm. It's not so foreign. But to our older population, it is. And regardless of age, learning how to diaphragmatically breathe and activate your diaphragm and create good breathing mechanics and even do respiratory muscle training can be so beneficial for so many populations. Back pain, get them breathing. GERD, get them breathing. Pelvic floor pain, get them breathing. Constipation, get them breathing. Actual lung disease, get them breathing. Heart failure, have to learn how to breathe. And the more we're able to cue in and tap in and understand another piece of our being, the more in tune we are as a human. I have lots of conversations and people in the space that I'm currently in this world of business, and we talk a lot about breathing and movement. And I'm going to give a shout out to my girl at JPB. She's Brain Body Resilience on Instagram. I'm going to give another shout out to my girl E Webb. I believe she's Erica Webb Self Kindness on Instagram. They are two amazing humans working with breathing and movement and nervous system hygiene and learning how to regulate your own body in times of stress. So just living in this world, it's really helpful to know how to diaphragmatically breathe. It's really helpful to know how to tap into our breathing to help control our situation. When I was in faculty, I would teach my students how to breathe and how to activate the vagus nerve so that they could come into a practical, come into a written exam, and tap into a calm system, a calm focus system, and not get overwhelmed by anxiety. So to, bring it back around, breathing can help with stress. And if you are a human in this world, you have stress. So learning how to breathe and tap into that system can be very helpful for you to regulate all of the things that we encounter in our everyday. So I don't know if it's common knowledge in the world of PT. It should have been. It might be cobwebs. You should have learned it at some point in your schooling. Maybe you haven't done it in a while. But teaching your patient how to activate the diaphragm is relatively easy, but there are some techniques and tips and tricks that we can do to help our patients cue. And I'm going to be very honest with you. Every patient's different. One cue may work for patient A that absolutely does not work for patient B. My advice is keep it simple. Start less. Less is always more. If verbal cues aren't good, go with tactile cues. If verbal and tactile cues are making your patient more anxious, then sometimes just breathing alongside them is enough to help match breathing. So a couple of things when we're teaching our patient to diaphragmatically breathe, we want to set them up for success. Okay. And so what that means is we want to put the diaphragm in a position that it can do its job. So we can help activate the diaphragm more effectively by the position our body is in. So obviously we can activate the diaphragm in almost any position, but depending on length tension relationship and other factors like our spine position, our head position can help activate or inhibit. So when we are talking about diaphragmatically breathing, you want to set your patient up for success from a position perspective. And when we're doing that, really all we're doing is shutting down the accessories. So in order to diaphragmatically breathe, you typically want to have the patient in neck flexion, and neck flexion is going to shut down the neck accessory muscles. We're going to encourage a posterior pelvic tilt, and shoulder position, pending if you're in supine versus sitting versus standing, is really a neutral position. You could even slightly internally rotate. And what that's doing is taking upper chest out, right? So if we internally rotate our shoulders, we're going to relax the chest muscles as well. So no matter if you're in supine or sitting or standing or actively doing an activity, you'll be able to activate the diaphragm more efficiently by shutting down the excess. Neck flexion, posterior pelvic tilt, shoulder internal rotation. Okay. And position matters. So if you have a patient that has never done this type of thing, or you have a patient who's having a really hard time activating, or you have a patient who has paradoxical breathing pattern where the diaphragm is moving in a opposite position than it should with inhale and exhale, I recommend that you start in the supine position. It is easiest to activate the diaphragm in supine. Now, when we're lying in supine, there are a number of factors. So I always want to have this like underlying, it depends, right? Like how many times have you heard that? But it does depend. It depends on the underlying diagnoses that exist because a supine position might not feel comfortable for a patient. So if you had your patient in flat supine, you could put them up on a pillow or two and just have them in a light neck flexion, and that's going to shut down accessories. You could have them in a hook lying position to more easily put them in a posterior pelvic tilt. You can put legs up on a chair or pillows to force them into that posterior pelvic tilt and sort of take the legs out of the whole picture. And then you just have them either purposely internally rotate or just relax arms on, body. When you're in that position, the diaphragm is going to be more easily accessed, activated. When you're in that position, the diaphragm actually sits very high in the thorax. So it sits higher in the supine position. So if your diaphragm sits higher, then you're going to have more excursion. Excursion's the fancy word that we like to use for movement. So when you inhale, the diaphragm should have inferior excursion. It should drop down. And when it does that, it's going to push the abdominal contents down and out of the way. Exhale in quiet breathing is really passive, and it really just is a rebound effect and comes back up and is going to help push that air out. So in the supine position, you typically have more diaphragm excursion, but less volume size because the abdominal contents will also sit higher up in the rib cage. So I'm going to come back to it depends. This would be a worse position for someone who is, for instance, pregnant or someone who has a more obese abdomen because the stomach contents in the supine position are going to put more pressure up on the diaphragm. And then now we have resistance with excursion. Most people will activate more effectively, more easily in that position. We'll get to another tip on how to activate if we're still having an issue. If we're able to activate in supine, you can also practice in side lying positions. Because the diaphragm is two separate hemidiaphragms, they sit differently in the side lying position. So the upside is going to be more up and the downside is going to be more down. So it essentially does exactly what the supine position would be on the top. It's going to have better excursion, less volume. Lower one's going to have less excursion, more volume. Switch sides. If someone has some discrepancies between rib mobility, this is another way to encourage that. Okay. If they can activate in supine, you could add resistance type techniques to it. If they're still not able to activate, you can do manual techniques that help basically scoop the diaphragm and encourage it to move. There's lots of techniques you can do to sort of help it along. And then if we can activate in supine, then you might transition to sitting. And now in the sitting position and the standing position, the diaphragm is going to rest more low in the thoracic cavity, and because gravity is doing its job. And so the abdominal contents aren't playing as big of a role of resistance, but we have less excursion, less movement of that diaphragm, and more volume. So some people will feel more comfortable, more confident in the sitting position. But if they can't actually activate, I would encourage you to try in supine first. Standing is more difficult than sitting, simply from the postural muscles that we're using and the ability to potentially encourage a posterior pelvic tilt versus an anterior pelvic tilt. But the rules still apply. Neck flexion, posterior pelvic tilt, internally rotate the shoulders. You're shutting everything down to activate the diaphragm. Now, we typically don't stand in those positions, right? And there are lots of different ways that we can pair breathing with movement to encourage more movement to get a better inhale. That's not what I'm saying. What I'm saying is you want to set the diaphragm up for success if you're trying to activate that diaphragm. From a different perspective, we can also use verbal cues to better tap in to the diaphragm. And so when we're trying to get someone to activate diaphragm, it's really important to use calm, soft, low voice to get that diaphragm to activate. When we use really loud, encouraging, shouting or just kind of being more boisterous, you're going to actually encourage more upper chest breathing and more accessory muscle use. So if you're trying to isolate the diaphragm, if you're trying to get that person to just activate the diaphragm and get that cue, soft, calm voice. Sometimes you can use counting to help cue them. Sometimes counting makes people anxious. So you just have to find what works for your patient or client. The other thing that I use quite a bit is just breathing. And what I mean by that is if I want my patient to breathe with a 1-to-2 ratio, a 2-to-4 ratio, 3-to-6 ratio, whatever it is that we're trying to accomplish, I just breathe a little bit more loudly so that they can hear my breathing, and then they tend to match you. This can be very effective in the ICU, can be very effective in patients who are anxious. Hands-on cues, just putting your hand on the diaphragm or hand on the chest wall could help calm that patient and just help them cue a little bit better. From a cueing perspective, the one cue that I don't encourage you to use is the term belly breathing. Breathe into your belly. And, it might work for some people, but the issue tends to be is that, number one, patients don't really know what that means. And so what they then think that means is when we inhale, we are pushing our abdomen out. And that is not what inhalation is. The reason why your abdomen moves out on inhale is because the diaphragm, the main muscle of breathing, is pushing down on those abdominal contents, and then those abdominal contents pop out from the pressure. It's not abdominal contraction. Exhalation in a forceful manner is abdominal contraction. So when you start to encourage the patient to belly breathe, they might actually get more confusing mechanics and could potentially lead to paradoxical breathing, or just they're not actually taking a bigger breath. They're just, pushing their stomach out. So I personally don't ever use that cue. I also don't like the two-hand cue, and I'm going to actually put my screen down for anyone who's on YouTube. I don't like a hand on the chest and a hand on the diaphragm in order to cue someone to diaphragmatically breathe. Again, it's not wrong. I just personally don't like this technique. And the reason is, once you put your hand on the patient, that person is going to adjust to that. There is a proprioceptive feedback that if I put my hand here, I might actually start breathing more into my upper chest. So the cue for people who use this technique is usually don't allow your upper hand to move, just allow it to rest and concentrate on the belly hand or the lower hand. It's a lot of work, right? That's a little bit of mental gymnastics. Don't pay attention to the upper hand. Just pay attention to the lower hand. But the brain is going to recognize it. And we actually use that technique with segmental breathing. We place the hand on a segment and have the patient concentrate on the hand placement to push more air and more movement into that position because that mind-body connection is so strong. So for me personally, I don't like a two-hand technique because I think it's really hard to ignore the contact. Tactile cues, hands-on cues is so powerful that we can't ignore that as soon as we place our hand on the upper chest, that we can encourage more breathing there. There are techniques where when you do that, and it can be an inhibitory technique. And essentially, you use a two-hand technique, and the upper hand is creating a down pressure to sort of prevent upper chest wall mobility. And then the lower hand is scooping with the diaphragm. For the most part, that can work, but it's really fun holding a class because let's say you have 50 people in your class. Let's say 35 of them can inhibit with that down pressure. But the leftover, was that 15 people left over? They actually might encourage upper chest breathing. So the point is that if you give the tactile cue, then you might lose out on that diaphragm excursion. So always try, right? I'm only here to give advice. I'm only here to give opinions and what has worked for me personally and on my own person, as well as with clients and patients that I see. It's not wrong. Lots of people use that cue. I just personally don't use it because I think patients have a hard time disconnecting that upper hand. I have used the inhibiting technique and it can be super effective, but like I said, some patients, it actually encourages that upper chest to start driving. You're like, all right, that didn't work for you. Let's try something else. So when activating the diaphragm, we're setting them up for success, and that's talking about what position we're putting that person in. We talked about audible cues. We're going to use soft, calm tones. We can use counting to help. Counting might make people anxious. If it does, back off. I actually just like to breathe with patients sometimes. So I'll just audibly breathe. And they'll start to match you. So play with different techniques, see what works for you, pay attention to what works for your patients, and then repeat. And what you're going to find out is that everybody's different. And some cues work great for some people, and some cues you really just got to like keep going down the list, keep reaching into that toolbox and try something different. One of my favorite tricks, tips, training techniques for diaphragmatic breathing is sniffing. So sniffing is a technique where you basically take the thought out of it. You have the patient, and I will do it like I do with my patients. You have the patient sniff one time like you're smelling a rose. Okay, so just one quick, stiff, short, quick, whatever word you want to put in there to describe it, sniff. So super quick. And while you're doing that, you are palpating the diaphragm. I personally like a two-hand technique. You can also do a broad hand technique, kind of right under the diaphragm. Right under the xiphoid process. You're assessing the diaphragm. I like a two-hand technique where you have your hands up under the rib cage. You're about like an inch below the rib angle. And sometimes you have to play with positioning. But when you get that first sniff, you're going to have your hands pop out, or at least they should, on inhale. And then you can assess side to side. You can assess timing. You can assess excursion. Lots of cool little techniques. I used to do the broad hand mostly. Now I typically use a two-hand technique and see if both sides are activating. So sniff technique is a way for you to see if we can override thinking, right? Like the person doesn't have to think about their diaphragm. If they've never heard of their diaphragm, it's going to be really hard to activate. It's not like bend your elbow, right? So the sniff technique overrides the thought process. It's my go-to start of any patient pretty much. Even if people do diaphragmatically breathe and have some knowledge, I start there. Just get the quick reaction, see what happens. It's easier for your eye to see, and you can do that assessment. And then when you're training it, you train it in sets of 3. So you do 3 sniffs in a row, and you don't cue the exhale, right? Because the goal is just to get them to pop, 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 and you get that diaphragm to pop, and exhale is going to happen, so don't cue it. If you're trying to get one thing to work, just concentrate on that one thing. I will say, as I've moved along in my career, I tend to combo things now, but I only do it if a person is ready and if they have multiple comorbidities where certain things will actually help combo them and we're not confusing the patient. From an activation standpoint and from a training standpoint, you do 3 sniffs in a row. Once they get that and they're able to do sniff, 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 and their diaphragm is popping out with each inhale, then you can have them start to extend the sniff. So then I go to 2, and then eventually I get to 1. And what you've done is taught that patient how to diaphragmatically breathe. Will that happen in one session? Not necessarily. Sometimes it does. Sometimes I just go through the whole technique. They can do 3, great. I can extend to 2, great. Let's move to 1, nailed it, and then you train from there. The sniff technique is also just a great way to get reps, right? Eliminate the brain, get more reps. And the other big thing that I haven't overtly said yet is when you are teaching your patient to diaphragmatically breathe, you want them to inhale through the nose, period. The nose has a direct connection to that diaphragm moving, and it has a ton of other benefit, which we're not going to go into today. But once you inhale through the nose, just like the sniff technique, you're going to get that diaphragm to pop. So inhale through the nose. Technically, when I'm teaching a patient to do this for the first time, I don't cue the exhale. So if they exhale through the nose, great. If they exhale through the lips, great. If they're having a really hard time and they're in an exacerbated sort of state, I cue them to exhale through the lips because it's less resistance for that patient. So the last thing I wanted to talk about just a little bit is inhalation and exhalation and what that means from a muscle activation perspective. When we inhale, diaphragm is going to drop inferiorly. That is a concentric contraction. Inhale is always concentric. And so this is a little bit more geared to my students who might be taking a test. If someone is asking you about concentric versus eccentric versus elastic recoil, inhalation is always concentric. And then there's a lot of theory that can go with that in relation to strength training and such. But when we inhale, diaphragm drops inferiorly. Lots of things are happening in this moment. I can just talk about this all day. This is why I probably have been like teetering on how do I want to approach this? Because now what you've done is created a pressure gradient. Something else that breathing helps with is increasing preload. And what that means is when the diaphragm moves, we are literally going to be changing pressure between the abdomen and thorax. And so what that is going to allow is movement from the abdomen into the heart on venous return. So breathing can help venous return, can improve preload. You can use this with someone who is orthostatic. You can use this with someone who's having pooling in their legs. You can use this with someone who's been on bed rest for a long time. You can use this with someone who, I mean, the list is going to keep going, right? I'm just going to keep adding to this. Pressure gradients run the body. So when we inhale, we are breathing air in from the outside environment. In order to get the air to go into our lungs, we have to create a negative pressure within our lungs. So when we inhale, diaphragm drops. When it does that, it increases the size of our lungs. We now have Boyle's law into this whole deal. And what that means is we've created a negative pressure in our lungs, or our pressure is lesser in the lungs compared to the environment. And what that does is it allows us to suck the air in. Exhalation's a little different. And it depends on what we're doing to classify exhale. So after we inhale, diaphragm's a little parachute, it drops down. We've created this lovely pressure gradient. When we exhale quietly, we're just sitting here listening to this podcast, maybe driving into work, that exhale is going to happen automatically. It's passive. So in quiet breathing, exhalation is passive because you have recoil of the lungs, literally just coming back down, and you have relaxation of the diaphragm, popping back up. And again, you've created a change in pressure. Now we have pushed the diaphragms up into the lungs, created a smaller volume, which is going to increase the pressure in the lungs, lower pressure in the abdomen, created that whole preload change. And now we can exhale out because the pressure in our lungs is now higher than the pressure in the environment. If we are talking, for instance, myself in this moment doing this podcast, how many words can I get out with one inhale? That is eccentric control of the diaphragm. That is control, a slow release of exhalation past the vocal cords for a certain amount of time to see how many words I can physically get out without having to take a break in this moment. I got a lot. Someone counted for me. So when we're talking, we are having eccentric control of our diaphragm, a slow, steady rise. When I teach students how to assess for this, there's a maximum phonation test, which is a great test of this exact thing. So essentially you say a vowel for an extended period of time and you time it. How long can you hold a note is essentially eccentric control of the diaphragm, because you have to slowly sustain that exhale out in order to create sound. So we create sound on exhale. If you have someone who is one-word dyspneic, they're one-word dyspneic most likely because they're not getting enough inhale. If I can't take a big enough breath in, I can't get any words out. Okay, so paying attention to how many words dyspneic can be a very clear connection to tidal volume. The last piece is that the diaphragm can also be concentric with forced exhalation. So a great example is coughing, sneezing, yelling, where you're aggressively pushing air out, and you're also getting abdominal contraction in that moment. That's why I have a really hard time with the belly cue, because you're not supposed to be abdominally contracting. You're not supposed to have a concentric contraction of the abdomen on inhale. Your belly's supposed to move in and out when we breathe. So when we inhale, we have that diaphragm excursion pushing down on our abdomen. That is always concentric. And then exhalation depends on what's happening. Quiet breathing is passive. It's literally just recoil, elastic relaxation, elastic recoil or relaxation, I should say. Some people, you could get little semantic-y on those words. Talking, singing, eccentric control. And then lastly, concentric movement of exhalation with coughing, sneezing, aggressive yelling, right? Blowing, like blowing bubbles. That's why when you're training your patient, you need to think about what cues you're giving. When I train a patient to extend their exhale, I don't say blow out the candles, because what tends to happen is you're going to get abdominal contraction. It's going to be fast and hard. I want you to extend eccentric control, right? So what you're doing has purpose. Pay attention to the words you use, pay attention to your hand techniques, pay attention to your patient's position, because it all matters. And it's all progressive. So you can change how you then, cue whatever. There are times where you may teach a patient to activate accessory muscles. A very common reason to do that is someone who has severe COPD and they have a flattened diaphragm, and getting it to move is really no longer an option. You might actually cue your patient to activate accessory muscles, and the positioning is different for that. You want to set that person up for success. In spinal cord injury type patients, C3, 4, 5 keeps the diaphragm alive. So if you have injury above that level, you're not going to be able to activate diaphragm. What you're capable of doing actively is going to be very limited. And some patients can utilize accessory muscles to help and use like gulping techniques and things like that. So when you're choosing to do a task, think about why you're doing that task. When you want to activate the diaphragm, you want to set that diaphragm up for success. That's your position. You want to use audible cues that are appropriate. Slow, calm voice, or just sound of breathing. Hand placement, your tactile cues. I prefer just at the abdomen, usually about an inch or two below xiphoid process. You can use a flat hand broadly across the belly, or I, again, sometimes just use the two-hand approach, 1 inch below the rib angle, and that's enough of a cue. Sniffing, another great technique to get that diaphragm to activate without the thought. And I'm not going to lie to you, taking the thinking out of breathing is very helpful. Once you put your hands on a patient, once you talk about breathing, you're going to change the person's breathing, their respiratory rate, potentially their anxiety, whatever the case is. How you teach them how to breathe after that, there's so many options available. Are you doing it for stress relief? Are we trying to tap into the parasympathetic system? Are we trying to improve preload? Are we trying to relax the pelvic floor and allow the pelvic floor and the diaphragm to work in unison? Are we trying to help a patient that has GERD? We have 3 openings in our diaphragm. And when we have GERD, we are literally able to basically massage that area. So we have esophagus, we have aorta. I just lost my third. I want to say zygus. But we can essentially help our patient move that diaphragm against our abdominal contents, create a pressure gradient. We're attached into our thoracic and lumbar spine. We can help with low back pain. No, I got them all. Esophagus, aortic, vena cava. That was my last one, preload. Ton of benefit. The vagus nerve is at this diaphragm, right? So when we are inhaling, exhaling, we're just getting a little vagal technique going there. Increasing our exhale taps into our parasympathetic system. The benefits are endless, right? And then you can start thinking about what's happening on the inside. We're getting increased gas, potentially to our alveoli, depending on what technique we're using. We're getting increased chest wall mobility, potentially. Once we move the chest, once we move the diaphragm, we're going to get volume of our lungs. So 100% benefit in teaching patients how to diaphragmatically breathe. It can even help with blood pressure and heart rate control. I didn't get into resistance training today. I'm going to do that in another episode. But when we perform resistance training to our diaphragm, we can actually decrease blood pressure long term if the person keeps doing that activity. We can control heart rate in that moment, right? As soon as we start breathing and tapping into that parasympathetic system, we can help heart rate come back down. So much benefit. But I am going to say one thing, because I'm not going to really go into resistance training today. When you are thinking about adding RMT, respiratory muscle training, which is literally resistance training for the diaphragm, using a breathing device, you are not going to do that You're not going to use that with someone who cannot activate without resistance. Pretty much like everything else, because then you can kind of put that person over the edge, or they're just going to be training in an inappropriate position. So always make sure your person can activate. And same thing, you might have to start in supine to then move to sitting, to then move to standing, and then move into functional activities, which is the most fun part about breathing, right? I think breathing is amazing. I think we have so much ability to make change to the whole system. I think learning how to breathe and tapping into our breathing can be super beneficial for a human to understand. And I think we all need to learn more about our body so that we can navigate life in different times and use our breath to help control the stressful situation, the GERD, the low back pain, the pelvic floor pain, labor and delivery, whatever it is that you're dealing with. I could pretty much guarantee that breathing is going to help in some way, shape, or form. Oh, I had one more. I have these like laundry lists going at all times. And I'm like, it's hard sometimes when you're mid talking, like, oh, I forgot that thing. Posture and balance. This can be super beneficial with patients with neurologic conditions, using breath control with paired movement to control posture, to control body and space. It's absolutely amazing. And the reason is because you're creating a pressure gradient in the cavity. And when you create that pressure gradient, you're actually creating stability. So tons of benefit: pain, stress, balance, posture. It's endless. So if you don't do any breathing practice, start simple. Lay on your back, neck flexion, shoulders internally rotated. Hook lying position means that your knees are bent and relaxed, or that your knees are up on like a couch or pillow. Posterior pelvic tilt, and just relax. Concentrate on inhaling through the nose, and honestly, it will probably just happen. If that doesn't work, place your hand on your stomach, concentrate on your hand. Inhale through the nose, concentrate on your hand. If that doesn't work, there are other techniques. You may need someone else to help guide you. If that doesn't work, try the sniff technique. And do it right now. If you're listening, put your hand on your belly, just below your xiphoid process, and just sniff one time, short and quick, like you're smelling a rose. And what should happen is that diaphragm should just pop right into your hand. You build from there. If you have any questions, if you are confused about positioning, if you have a patient that just is really having a hard time activating and you want some tips, tricks, advice, I have one-on-one mentoring sessions to help work through cases. You can reach out to me on any time on Instagram, through DMs. You can shoot me a text at 913-308-4494. I am very available and willing to answer questions. If it's more than just a quick text, set up an appointment. Let's chat. Let's help our patients. Let's get the most out of our person, or sometimes ourselves. So if you ever have any questions, reach out. Go to my website. One-on-one virtual mentoring is where we have these types of conversations. If you're just struggling with your patient, you don't know where to start, you don't know where to place your hands, you don't know what cues to give, or it's just not working and you want some guidance, I would love to help you with that. If you are studying for the MPT, if you're in a cardiopulm program and you're just like having a hard time with these concepts, reach out. I do mentoring one-on-one. I have webinars, MPT prep course. We go through all this stuff in detail, PowerPoint slides, the whole bit. Whatever you need or whatever would be helpful for you, reach out, let me know. I am happy to talk to your class, talk to your program, talk to your PT department. This is the stuff that literally gets me fired up and is so beneficial that every single human should know how to perform and then progress from there. And that is my mission, right? Like, let's do the thing. Let's help patients activate diaphragm. Let's help them breathe better. Let's get the most out of our patients in the world that they're currently in. Let's let them thrive. And that all starts with breath and breath control. And that can progress to all sorts of things. So if you have any questions, if this was helpful for you, please reach out on the Instagram. I'll give you that phone number again, 913-308-4494. Please send a text. I wait to go to voicemail because I get all these random numbers coming through there. But DM, text, email, I'll answer you within the day or whatever. And if I don't answer right back, send another message. It may have gotten lost in the shuffle. All right. I hope you all have a wonderful day. Whatever you have to do, get after it.